Place your name and campus in the chat. Good evening. Hope everyone is doing well. Ensure that your name appears how it appears on Fortis's roster, your first and your last name. Ensure that your cameras are on and that you're visible. In the event that you are not, have to step away, use the restroom or something, put a message in the chat to myself. Just as a reminder, these sessions are recorded and they are viewed by the attendance administrators. Give everybody a minute or so to put your name and campus in the chat. Well, welcome to week 5. It moves pretty fast, you all, going forward. So for this week, let's see where we're at here. Pull up and share my screen. Okay. So this is week 5. You do have NCLEX questions. We will have a quiz. Then next week, we do have unit exam 2. And then that professional development plan is due. Remember with these, this plan and any other papers that, and this is for all of your courses, if you have a paper assignment that is similar or the same, let's go in and paraphrase it. Make sure that you're citing up-to-date resources so that your plagiarism score, so you don't plagiarize yourself, because if you have a similar assignment, we kind of say the same thing, almost the same way, but go in and paraphrase it, read some new sources so that you can cite, within that 5 year and just paraphrase or restate what you're saying so that your plagiarism score will not be high. So that's what any of the papers that you're doing for any of your classes. And then we have the exam. And then we will be, after that, we'll be kind of halfway. So that's where we're at. So let's go ahead and, so I am sending to you all, to your Canvas boxes, a message that says activity. So, oh, wait a minute, it didn't send it to you all. Let's see here. All students and send. It's still spinning, so give it just a moment. So log into your Canvas mail, not your Outlook mail, and just look for an activity that I just sent to you all. It's, I think, 8 slides we're going to go over. So the task is opening up the email that's in your Canvas mail. It's an activity that has about 10 slides, and we'll spend like 10 minutes letting you all talk in small groups about what's on the slide. So really talk it through, and then we'll come back for whole group and we'll review it. So I'm going to open the breakout rooms and let you all can share your screen or pull it up. You can do jot noting, however you want to do it, but at least discuss what's on the slide, and I will circulate to the group. So it is in your Canvas mail. It's a mail that I just sent you that says activity. And we open up the breakout rooms. Let's see here. Okay, and accept the invitation. I'll be around to listen to you all's discussions. Okay. Let's go here. All right, so good evening. You need to look in your Canvas mail. I just sent an activity to you that has about 10 slides. Do y'all have it? Not your Outlook mail. Okay. All right, so we'll give you all, let me set a timer. I'll make sure everybody have it. I'll be back and we'll close the rooms out. Let's see, leave the room. All right, we're in the breakout rooms. If you would go ahead and place your name and campus in the chat, and I'll put you in the breakout room. You have been given an activity. It's in your Canvas mail. And the task is just opening it up and at least having a discussion about it. And it should put you in a room. Did you get an invitation?
Yes.
Okay. All right. So we'll give you all, let me set my timer and then we'll come back and discuss in whole group and then we'll move forward. Okay. Were you able to find the activity in your Canvas mail?
Yes.
Okay. So just have a discussion. Let me set my timer. I haven't set the timer yet. So we'll give you about 10 minutes or so. You don't have to write down anything unless you want to, but just make sure you have a good discussion and what you have questions about. Make sure you bring it back and we'll make sure we answer it.
Okay.
And timer.
Did you guys find it?
Yeah, I have it.
Okay.
I believe the other one is just the next one is to just contact the pharmacy.
Okay.
Mm-hmm. And then justice refers to like
Were you all able to find the activity in your Canvas mail?
Yes.
yes.
Okay.
I think we were on the what should the nurse do? The patient is in room 201.
What the patient doing in 201? That little patient, he stays in room 201. What are they doing in this scenario?
I'm sorry, what was the question?
What does the slide say? What are you reading? What's the patient doing in
Oh, it
201?
just says that he's out of medication.
Okay. So
And
what
I think that they should double check the MAR, make sure that it's not available. And then I think that they should notify the pharmacy. But I don't know if they're supposed to go to the charge nurse first or not. Because when I was doing my clinicals, they said if stuff is almost ran out, they already have put in an order for it to be like renewed.
Replaced, I guess.
Yeah.
reorder?
Yeah.
Yes, they do have systems. Some facilities have it where the facility that you were at, did they have cards? Okay,
Yes.
did you look on the card? Were the cards the same color or was one row a different color?
One row was different.
Okay, so when you get to that top row, if you're the person that's punching out the pill at that top of that different color, most of the time it's blue or red.
Mm.
And then that means you go in and click the button that says reorder. That's like it's an unsaid rule, but we know when you get to that row that's a different color, it's time to reorder. Because what pharmacy does, they package a certain amount of medication in that card. And so remember, you got to think about who's paying for it. Your insurance only covers so many pills within so many days, and also all that is taken into account. So when you get to that card, that row, that means you reorder. Now, most systems have where you can actually click the button and go to that medicine and click and say reorder. Some facilities, you have to pull the sticker and put it on a paper and scan it to the pharmacy. But either way, you reorder that medicine. Good. That's a good point.
Little and demeaning remarks of a patient's condition.
Mm-hmm.
Based upon law, which situations must be revealed to the appropriate authorities? Fraud.
So fraud would fall up under what big category?
Oh, hey.
Okay.
I was like, wait. So you just threw me off.
Let me see.
Like for example, too, like if we're charting things that are not correct, that didn't happen, we're using the patient's funds.
Or taking also, like for example, using materials that are not needed for the patient. And charging their insurances so we can get back from it.
Exactly. Did you get, let me see, which room were you in? Okay, I see you. Both of you all were in the same room. You all got bumped out. Let's see here. Let's put you in the room.
Let me see. Hold on a second, please.
All right, so we have about 45 seconds. Everyone should be back. So we're going to take those slides and make sure we have a good understanding. And then the things that you still have questions about, please ask. So we're going to go over them together in a whole group. Then we'll give you about 3 minutes to just think about what we talked about, and then we'll take our quiz. So let me share here.
Okay.
Let's see, slideshow. On the current slide. Do we have everyone back? I think we do. Make sure we're recording. Yeah. All right, so ethical principles. So what comes to mind when you hear the word ethical? Is it deciding what is the right thing to do, what is the wrong thing, what should be done correctly? These are just words that may come to mind when you're thinking about ethical principles. But they are fundamental to the nursing profession. It's an honor system. We're expected to do the right thing. That's our little timer, no matter what the situation is. For example, if the patient doesn't have insurance, if they are underinsured, if they're non-compliant, it doesn't matter. That patient still receive that same professional care with integrity. We don't overuse supplies for a patient, but we provide that ethical care for them. Where can the LPN find the minimum competencies required to practice safely? So what are competencies? What are they talking about here? What's another word we can use for competencies? Let me hear from you.
The State Nurse Practice Act.
Okay, so that is where we can look. And so when we're talking about minimum competencies, it's like the nurse state practice. It's our to-do list. Like it's our task list. It's our responsibilities as that nurse. So this is what they're saying those competencies are. And it comes from each state's Nurse Practice Act. It is important that we know what our scope of practice is. Unfortunately, I mentioned it before, sometimes people will ask you to do things that you're not supposed to do. They'll send you in, well, you go ahead and start the teaching. We know we can't start the teaching because what do we as LPNs do? Do we start the teaching or do we reinforce the teaching?
Reinforce.
Exactly. And it may seem minimal, but no, we don't want to practice outside of our scope. We don't want to practice or do anything that we're not supposed to. So these competencies are things that we can lawfully do. And we'll talk about it a little bit later, where sometimes our personal and professional ethics bump heads. But where can we find our minimal competencies, the minimal tasks, the things that we can do? Well, we go to that state nurse website, that state nurse practice act, and we go to different. If we have license, if you're a multi-state license, then you still have to. If you're in Florida practicing, you need to look at that state's Nurse Practice Act. Yes. And then they all have those websites you can go to and you can easily locate those things. And you'll have your own login anyways on those on each state's Nurse Practice Act. Practice each state's nurse website so that you have those things available to you as well. So Nursing Practice Act, our to-do list is those things that we can lawfully do. It is our guideline of what actions that we can legally do. It is guided by the state statutes and it is considered the law. Okay. What should the nurse do? The patient in room 201 is out of medication. The medication is due now. What should the nurse do?
Shouldn't they contact like the pharmacy?
Okay. Contact the pharmacy because
Or
there's usually go ahead.
doctor?
So the pharmacy, the healthcare provider, you all talking, I was circling around to some of the groups. There's some things that you can do. There are procedures in place so that a patient does not run out of medication. But we do know sometimes it just happens because maybe someone did not follow the procedure. Because we mentioned that most facilities have like packets, and the packets are the cards that the medicines are on. That last row has a different color, and that's a signal that says, hey, it's time to reorder. We don't really think about it, but medications, how are they paid for? If the patient pays for them, if the insurance company pays for them, then the insurance company pays for a certain quantity. It goes back to, well, how much did the physician actually order? So if they order only 30, that's the only amount that will be dispensed. In addition to their insurance company says that it is okay to dispense 30 pills. There are some instances, especially with the shorter stays, like the ones that come in for like that 21-day stay, their medications have to be reordered every 7 days. But nevertheless, there's a policy and procedure in place so that that patient does not run out of medication. Because in fact, if a medication is due and we don't have it to give, we're in medication error. That has to be written up. Everyone has to be notified. So we want to follow those policy procedures so that we do not run out of medication. But in the event that we do run out of medication, do we want to borrow other patients' medicines?
No.
Let's go. Nope. Not unless we're not borrowing medicine. Now, there are some what we call OTCs, over-the-counter medications, or we call them stock meds, that facilities, they will have like these gigantic containers. A lot of times you see like Tylenol, the aspirin, and some vitamins. The container will hold 1,000 pills, but those belong to the facility. So each patient can use out of that container. But if the card has the patient's name on it that's in room 201, the patient in room 202, they have the same medication, the instructions are the same, we cannot share those medicines. We have to, in fact, contact pharmacy and say, hey, we're out of those meds. We don't know really what happened, but nevertheless, the medication is not there. What pharmacy will do, they'll check their system to see, has it been dispensed? Because the pharmacy just automatically sends those medications back out and they've already been delivered, then who's going to pay for them? Where are those pills at? So we have to notify pharmacy, and they'll get them out to you. Even their after hours, they have an after hours process, but it is unethical and illegal to use patients' medications for our own use, for the nurses' use, and for other patients to use. So we don't share medicines. There is a procedure in place if the person is out of medication. Contact the pharmacy. Okay, so I think we were supposed to discuss beneficent paternalism. It is where the doctor is seeking, the healthcare provider is seeking the court's permission to treat a minor against the parent's wishes, the parent or guardian's wishes. So this is the scenario. We have the patient in room 201. They are a child. And the parent or guardian, they decide to select treatment A. The healthcare provider, the doctor says, no, B is a better choice, whatever it is. So the healthcare provider are they supporting autonomy, or are they going against autonomy when they say no? They're
going against it.
Going against. So it's considered to be disrespectful. It is the opposite of autonomy. It goes against autonomy. But beneficent paternalism is only used for emergency situations. It's not something that you see every day that you're going to hear about. But it is the healthcare provider saying, hey, I know the best option. You don't know the best option for this child. And the procedure is that the courts are petitioned. Does not mean that the courts will, go with the parents or go with the doctor. It's just a procedure that is in place. But we need to know beneficent paternalism is used for emergency situations. It's considered disrespectful. It's saying, I know what's best for you attitude. And it's where the doctor seeks the court's permission to treat the minor, regardless of what the parents are actually have said or decided. Okay. All right. So justice. Justice refers to providing that fair and equal treatment. So the scales are the same, no matter what the person's pay status is. If they're uninsured, no insurance, if they have the best insurance, we still provide that same care, that fair and equal treatment. What if our patient is they're non-compliant hypertensive patient? They don't take their medicines. We can look in the system. We can see they haven't even got their antihypertensives refilled. When they come in, they're in a hypertensive crisis. Are we going to not treat that patient with the same care, or should we?
No, we should treat them with the same care.
And that is justice. No matter if they're an alcoholic, if they are non-compliant diabetic, if they keep falling, they keep coming, they're frequent flyers, we still provide that same equal care for our patients. That is what justice is. Okay, so here we go. We got beneficence. Is what we're doing benefiting, or are we doing good for the patient? In the example that I have here, questioning an order. I think the example that I gave you all last week, we have a medication we're administering to a patient. The example here is, I guess it's an antihypertensive. We check the blood pressure and we notice a change in the patient. We check the blood pressure, we notice that it's low. This has happened twice now. We've noticed that is right after we give this blood pressure medication. And we have assessed their level of consciousness. We have checked their vital signs. When we get an abnormal finding, what do? We recheck it. We verify it. We have rechecked. This blood pressure is still low. So keeping beneficence, doing what is good, doing something that's going to benefit this client. What do? We pick up the phone, and who do we call?
The doctor.
The healthcare provider. Yes, because they need to know, hey, yes, we have this order on our screen and we're going to administer this medication, but these are our findings. This patient may need a different dose, might need a different medication. They may skip some doses, but nevertheless, we need to notify that healthcare provider, and that is considered doing things that's going to benefit or do good for our patients. Let me read the rest of this. Emphasizes nurses' obligations to promote their patients' well-being and interests. We're that advocate. We speak up for them. It involves actions that aim to do good, to benefit them, which leads to improved health outcomes. Because what if we keep giving this blood pressure medication and it keeps dropping their blood pressure? This patient's gonna soon, they might not have any vital signs, but for long, if we continue to give this medication, it's dropping their blood pressure. Well, we're seeing that change in mental status, and we actually have those objective findings where we're getting that blood pressure reading that's really low. And as a result of us notifying that healthcare provider, it improves that patient health outcomes. We're like that lifeline, that go-between. We're the eyes, the ears of that healthcare provider because they're not there. So beneficence, the things that we do that's going to benefit that client. All right, so now we have fidelity. Refers to keeping one's promise and acting in the client's best interest. So being faithful, just keeping the promise, being faithful, committed to providing that best care possible for that client. It all involves being truthful. Hey, I said I will be back in 2 hours. Let me go down here and tell them, hey, it's going to take me a little bit longer. So just going back and saying, hey, I've run into something, just letting them know that strengthens that therapeutic relationship between you and that patient as well. So an example that we have is intervening and stopping several coworkers that are making insulting or disrespectful, belittling, or demeaning remarks of a patient's condition. And so we're acting in that client's best interest when we intervene. And the reason I put all these different, like making, insulting, being disrespectful, as you read your answer choices, think about the words that are there. So what is this word? What's another word for this word? Like we say tomato, tomato, we're still talking about the same thing. So make sure that you don't change the name of the word, don't change the definition of it. But what other word or term or concept means the same thing? And that'll kind of help you kind of narrow down and remember which concept is which concept. So that's why I like to give these different examples here. Okay. Based upon the law, which situations must be revealed to the appropriate authorities? And so I've heard some of you all's discussion, but remember those gunshot injuries, even if the person said that they were playing around, they made a mistake, they can pull out their what's that card? Their certification that shows that they went to gun safety class. We still have to report or reveal that gunshot injury to the authority. So as you're taking care of that patient that's coming through the ER, that charge nurse or someone, they're reporting it. It has to be reported. Someone that has suicidal ideations with a plan, we need to report that. And then reaction to a medication. Most of the times, if you're in the urgent care or even in the doctor's offices, they administer your medication, whether or not think about, well, what's the medication? It could be a vaccine. It could be Tylenol. It could be a steroid shot. It could be a Rocephin, an antibiotic shot. They receive that medication. You're supposed to sit that little time, and we observe them to see if they're having any reaction. Now, reactions can be extreme or they can be mild. So it can be anything from an itch at that site. It could be a rash. It could be, they're having trouble breathing, anaphylaxis. So any type of reaction, we must report that, whether or not it's a vaccine, Tylenol, whatever it is to a medication. All right. So malpractice. While helping a client to the bathroom, the nurse took a phone call. The patient fell while the nurse was on the phone. We remember, was this patient assigned to us? Yes, they were. What was our duty? The care plan said that this person was supposed to be assisted by one person. So we assisted them to the bathroom, but then we stepped away. Well, we took a phone call. So then we were no longer assisting them. And as a result of that, they injured themselves. They fell. So is there a connection, what they call a proximate cause? So did the nurse breach of duty, but the care plan say one person should assist, them stepping away to take that phone call, cause that injury? Did that cause them to fall? So in the event that we do have all those connections, as malpractice. Okay. So we have non-malfeasance. The duty to ensure that the patient is safe, ensuring that we have a safe environment. We're making sure that the beds are in the lowest horizontal position, call lights are in reach. Non-malfeasance. Safety, safety, safety. One of those things that we do. And it's like an automatic, before we leave the room, we turn back and look and make sure those beds are down. Because if they fall, then that lessens the impact of that injury. If they fall from a shorter height. All right, so I'm going to pause. Let's pause 3 minutes. We'll let you all ask about any of those concepts. So we do have about 9 seconds left. So do not start the quiz yet. But you can go ahead and click it. It's either in the grade book or you can go to the modules. I will put the password in the chat. Remember, you have 15 minutes to take this quiz, you all. So you do have the 15 minutes. I will put the return time in the chat. So in the event that you finish at 13 minutes or 12 minutes, you can go off camera for that time, but make sure that you're back on at that return time so we can go ahead and cover the rest of the content. But remember, you have that 15 minutes to take the quiz. Make sure you read through each scenario and answer accordingly. Okay, so the quiz should be there. Let me put the message in the chat, and I will go on mute. If you have any questions,
Mine is like,
Mine says it's locked.
and saying it's locked. Okay, let me look at the time then. I said it. I know we're the quiz is 3 hours. Miss Smith, was that something I need? Okay, I see what I see what it means now. I see it. Let me go and look at it because it's a 3 hour time difference for the quiz. Let's look and see. Let me edit it. But you will need the little code. Oh, so yeah, because it's 9 o'clock our time. I keep forgetting that y'all are an hour out, but this is on Pacific time. So let me adjust it here a couple of hours. Yep, it is locked. Let's see. Yeah, that'll get it right there. It's not published just, it's not open just yet. Hold on, y'all. Don't click it yet. Thought I had it set and ready to go. Okay, so it's 9:08 your time. So this thing is yes. I put it for 9 o'clock because it's 9:08, 9:09 specifically. All right, now I'm gonna hit save. Let me know if you can see it, and then I'll put the code in the chat.
yeah. You
Okay.
can see it.
All right, so let me put the code in the chat. So if you have any questions or concerns, put them in the chat. You do have the 15 minutes. Don't come off mute. And so it is a 5 and an S. And so just to let you know that part, I'm hitting it out to everyone. I'm going on mute. I'm going to set my timer and I put the return time in the chat. If you finish before the 15 minutes, you can go off camera. Just make sure you're back on. Okay, I'm going to be quiet. All right, so let's come on back. Our time is up for our quiz. All right, so let's regroup you all. So I want you to look at this slide. Okay, so tell me what is beneficence. How do you remember what is beneficence?
To do
Not
good.
okay, to do good. I was gonna say not beneficent paternalism, but beneficent, to do good. Okay, do we all agree or does anyone disagree? And if you have another way of saying to do good, please share that. Okay, I'm not hearing anything. So to do good. All right, so let me share my screen. So we are trying to determine which scenario is to do good because it asks you specifically about, we just said beneficent. We just defined. So when you're reading through the scenario, you identify, well, what is this question about? So the question was about beneficence. We just said that. We just said, so go through your file. So what does beneficent mean? It's to do good, things that's going to benefit this client. Read this first scenario for me and tell me whether or not this benefits. Does this do the patient good or does them no good? Just read this first one here.
Does no good.
Okay, read the second one.
Does no good.
Okay, so what's wrong with this first one? What word? Remember, test taking tip. One word throws this whole thing off. What three-letter word throws this off? Not. So take the time to read because these are the answers that you all selected. If you got this question wrong, these are the two answer choices, and I said, well, you must have didn't see this right here. So take the time to read it because these three letters change this whole thing. We said beneficent. It's to do good. This does not do any good for this patient. This one right here says a nurse that has given their personal phone number to a client's family member to call if they have questions about the care their family members receive. What's wrong with this whole scenario? What are we doing?
Why would you give your personal phone number out?
And also, we're offering to give private information out.
Right, that's against HIPAA laws.
HIPAA, exactly. This is not doing the patient, it's not doing the nurse any good either because they get ready to go to prison because they're releasing private information. So take the time. You got to know the concept, you all. You got to know the concept. Just like we just broke it down. I asked you what was beneficent. You all told me what it was. So then we're like, okay, we got to apply it to the situation. If it does not match the definition to do good, we're not going to select that answer choice because it's incorrect. All right, so let's do one more. Let's see. All right, so let's look at the screen. Let me put it here on this one slide. Okay, so this slide says, it's time for us to take our little break here. We're gonna go through this one and we'll take our break. Is it unethical and illegal, or is it ethical and illegal? Are these saying the same thing? Are both of these answer choices saying the same thing?
No.
No.
No. So again, watch what you're looking at because right here, these two letters change this whole word. Because if it's ethical, that means that's something good. But if it's unethical, it's bad or the wrong choice, whatever words you want to use. But then right here, it's illegal. So how can something be good and illegal? That's not matching. Okay, so here we go. So first of all, I think what tripped you all up on this one is you all didn't realize that these were different words. You didn't see those two letters. So a lot of you all selected this one after saying it was ethical, but it was illegal. They don't match because we said ethical is, the right thing to do. So here we go. The scenario is to use the patient's medication for personal use. So can the nurse use the patient's medication for their own use?
No.
Can we use another patient's medications for another person?
No.
We can't share. We have to notify the pharmacy. All right. So with that being said, is this situation ethical or unethical?
Ethical,
Okay. And also, it is also what? Illegal.
illegal.
Yes, because we can't be taking people's medication. That's a whole crime. Not only is it unethical, we're crossing over that line to being having charges and things brought against us. Because especially if it's a narcotic and you test and don't have a prescription and do a drug test, then you gotta show proof that why is this in your systems? And it's also illegal. So, but ethical and illegal don't match. So this couldn't have been an answer choice. Because yes, while this is illegal, it's not ethical. So someone else come off mute and explain or give your way of explaining why the answer is that this scenario, nurse using the medicine for someone else, why is that unethical and illegal? Let me just hear someone else explain that. Why is that unethical and illegal? This is a safe space.
So, okay, go ahead. Go ahead. Okay, well, what I think it's illegal is because it's violating the the drug control laws, and it's unethical. Ethical because it violates the nurse uh professionalism. Like sharing the medications.
Exactly. So if you have to talk through talk through the situation or the scenario as you read the answer and the answer choices, please do so. That's why I reminded you all that you all had that 15 minutes. A lot of times, you take the quiz and everything way before the time. But take the time. Those two little letters changes that whole word, the meaning of that word. And it means that you shouldn't pick it. Okay. So let's stop and take
I
our
was
first
gonna
break.
say that it was also violating one of the 6 rights too.
Exactly. It does. Yes. So that's again, stop and think about because you all have all the information. So think about it and put it all together. Wait a minute. Okay, that's this file. What are the rights for medication administration? Okay, wait a minute. We giving out information. That's HIPAA. So think it through. Good. Thank you. Okay, so 9:34 it is. So return at 9:40. 5-minute break. All right, let's get back at it here so we can cover our content. Let's look at this slide right here. Okay. So the Nursing Practice Act is our to-do list, is those things that we can legally do. It is a nurse's guideline of what actions the nurse can legally do, that we can legally do. It is guided by that state statutes and it is considered the law. Because that's what they're going to go back to. So if they call 1-800-DOLLAR-LAWYER, they're going to look back at the Nurse Practice Act. Okay, well, what can this nurse lawfully do in this state? This nurse is in Florida. What does the Nurse Practice Act say they can do legally or lawfully? Okay, and then from that, the facilities create their policies and procedures, and they should match also that Nurse Practice Act. So they should mirror. So those things are, if they call 1-800-DOLLAR-LAWYER, they're going to look at that Nurse Practice Act, and then they're going to look at that facility's policies and procedures because they should match. Okay, with us knowing that, I want you to read this statement right here and tell me whether or not it's true or false.
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 What word makes this false?
Another state.
In another state.
Another state. Because remember, you have to, no matter if you have multi-state license, you still, once you go to that state, Florida, you have to do whatever is lawful there. If you go to Alabama, you have to do what's lawful there. But that compact allows you to just purchase that one license. But when you go to that state, you still have to follow what is legal for you, what is the law in that state. So when they put the word in another state, that means that this nurse is have their license in Alabama, and then they're over in Florida doing what they would do in what the Alabama Nursing Practice Act says that they can do. So that is false. We can't do that. All right. So just taking the time to stop and read, you all. That was the other one that was missed the most, because that we didn't see that word. So I think you just didn't see that word, that phrase, another state. So then that changes the whole scenario. All right, so let's move forward here. Let's see. Let's see here. I'm going to share my screen. And again, make sure that you're going back, reading through, listening to all of the classroom recordings. Make sure you go back through those, you all, and you're looking at your PowerPoints and everything that we are sharing with you in the some of them I've incorporated inside of this PowerPoint, but still make sure as you continue to look at it and look at it in different formats, it will stick with you, and then you'll be quickly to identify, well, hey, I need a little bit more discussion on this topic right here because I don't quite understand it. All right, so let's just go. We're going to cover everything. What happened with that? Okay, let's see. Okay, here we go. And from current slide. Okay, that was a user. I think I told you to go back to the beginning. Okay, so here we go. We talked about ethics. Is it right or wrong? It's that guiding principle that says, hey, we should do this or we should not do this. Okay, if it says we should not do something, is it considered right or wrong? If we're saying we should not do something, if it says that we should not do something, is that saying it's right or wrong?
Wrong.
What'd you say, Aaliyah?
If you're saying don't do it, it's stating that it's wrong.
It's wrong. So when you read the answer choices, if we're saying something is unethical, make it match. I'm trying to just give you different scenarios of how to think about the concepts and to be able to apply them to what you know. Okay, so ethics is a system of standards or moral principles that direct our actions. It directs and guides what we do. Okay, we shouldn't do this. Like the scenario, I think in the question on the quiz, it was asking about one of the scenario, the answer choices was they overheard their coworkers laughing and talking about the patient that had some type of issue. We know that's the wrong thing to do. So is that unethical or ethical? If they're laughing and talking about or belittling the patient?
Ethical.
Unethical, because that's the wrong thing to do. Okay, just trying to break it down so that we can match it and make it, make those connections. So professional and personal ethics. So what in the world is this? So we just said the Nurse Practice Act is those things that we can lawfully do. If someone dials 1-800-lawyer, they're going to go back to that Nurse Practice State Act and say, hey, this nurse is in Florida. They are practicing according to the Nurse Practice Act. You have no grounds for suit. But personally, sometimes, depending on the setting that we're in, even though that state Nurse Practice Act says that we can lawfully perform or participate in certain procedures that patients may have done, personally, we might have an issue with that. We may think that it is the wrong thing to do. So that's when the personal ethics and the professional ethics will bump heads. So as you go through your clinical sites, be thinking about what you're doing. Like, what are you observing? What in this setting, what all do the nurses do? What all do they take part in? Because personally, for example, now I'm just going to just use something, for example, clipping toenails. They clip toenails all day in this facility. You might not want to clip toenails. So that might not be a place that you want to work, but here'd be another scenario. They clip toenails and they also do dressing changes. You don't really have an issue with the dressing changes, so you might want to work there. So that's a conversation that you will have with your supervisor to say, hey, personally, I think this is the wrong thing to do, to clip people's toenails. So I know the Nurse State Practice Act says professionally I can do this because it's lawful. And so, you all will work out some agreement, and or you may have to just decide to go work somewhere else. But personal and professional ethics, they do, they bump heads. Sometimes personal ethics bump heads with what the Nurse State Practice Act says that we can lawfully do. So we don't want to complete that task. You want to consider the different settings and what tasks are required. Is this task something that I, as a nurse, have an issue or a problem doing? Now, that's my personal. I think it was something else I wanted to pull out. But what could be another example of different procedures? I can't think of one that was in the news, but the whole premise is whatever procedure that's being done in that facility, if you have an issue, if you think it's wrong or unethical, then your personal ethics will bump head with your professional ethics. Okay? All right, ethical responsibilities of the nurse, client advocacy, accountability, that colleague reporting, like that scenario that we just had. We were talking about the patient, the nurses or the healthcare team were talking about and making fun of the patient. So here are these principles again. Can't get away from them. We're going to have to be able to apply them to a scenario. So make sure you go back and look at this recording because we got different scenarios in the recording. So now, non-malfeasance, do no harm. We just talked about beneficent, doing good. Autonomy, auto, that patient making their own decisions, free to choose. And we support them in whatever that is. What if the client says, hey, I want to have this hip surgery, but if I need blood or blood products, packed cells, plasma, whatever it is, well, I don't want that. Can that person, that patient, decide to still have that surgery done, even though in the event that they may need blood or blood products, they've chosen not to get that? Can they have that surgery, go on with that surgery?
Yes.
Yes. Very important. If you don't understand what I'm talking about, you all, I need you to stop me and ask me to repeat it. It's very important you understand these scenarios and I'm getting you all to apply to the ethical principles. So again, we just said autonomy. That person is free to choose. So the scenario I gave you was the patient's having hip surgery. But they always ask you when you're having surgery, well, hey, in the event that you need blood or blood products, you can go ahead and sign off on it. So if you need that, we go ahead and give it to you. And so, yes, the person can choose. They're free to choose. We just said that. They have the right to make their own decision. They're free to choose. Surgery, no blood and blood products. Okay. We talked about fidelity, keeping one's promise, and we said justice. No matter if the client has, if they're alcoholic, they're non-compliant, we still provide the same care. That's what we're in the business of, providing the best care for everybody. This is more on autonomy, thinking through all the facts, deciding on the basis of an independent thinking process. So this patient has the right to determine what they want to do. But we want to make sure, though, that they have enough information so they can make an informed decision. So they can exercise their autonomy. That auto means self. Okay? So what if we go in a client's home? We're doing home health. They have a cat in the house. They have clothes on the chair. They haven't folded up. They have dirty dishes in the sink. The scene is safe. We can still provide the care that we need to for the patient. They're safe. We're safe. We have that non-judgmental attitude. That's what that's called. As long as the client's home may not be up to the client's standards, but as long as it's a safe environment for us and the patient, we move on with the care. You know, they fold their clothes up and wash their dishes whenever they get ready to. That doesn't have anything to do with us providing that best care for them. So we should have a non-judgmental attitude. No judgment. No judgment. That's what that's saying. Okay. So beneficent paternalism. So tell me about it. Somebody come off mute. Tell me what you remember. Beneficent paternalism.
It's when like the provider makes the decision for the patient, what they think is the best decision for the patient.
Okay. Good.
Not giving the patient autonomy.
Get exactly. Yes. So bring that other word, that other concept that is opposite of autonomy. It says, no, I don't care about what you decide. It's a disrespectful attitude. And then don't forget, it's used for emergency situations. So it's not something that we're going to be seeing a healthcare provider do every day. It's where they go and petition the courts. They say, hey, we want the courts to hear our side. Yes, the parent or guardian has says, I want option A for my child. But then the healthcare provider says, no, treatment B is the best. And so it goes against autonomy. Good.
And I have a question, Ms. Morton. So that is always applying only for a minor?
That's usually when it applies. Because then that patient, because the healthcare provider is thinking, it's like the parent or guardian is making the decision for this child. So it's always in the situation where someone else, like a what's the other word I'm trying to think of, you all, where they're an adult, but they require someone else.
A guardian.
They require that guardian if they have a guardianship over someone. So it's still that same situation. Someone else is making a decision for the patient, whether or not that patient can be an adult. What'd you say?
Guarantorship.
Guarantorship. So that patient can be an adult, but someone else has that guarantorship or that right or that or has the right to make decisions for them.
Okay.
But if the emergency situations, it's a disrespectful attitude. It goes against what the patient's the parent or guardian has decided. Okay, let's see what I came up with here. We got Dr. Bob. Provide specific care based on a request. Okay, so we got two situations. Let's see what I did here. So read the situations here. Dr. Bob tells the client that treatment option, I don't know, A, B, C, or D is the best and they should choose. Which one is an example of beneficent paternalism? The first example or the second?
The first one.
I think the second one.
Okay,
Yeah, the second one.
We have the first one and the second.
I think the number 2.
Let's go back.
Yeah, the second one.
So why is it not the first one? What did we just say? Beneficent paternalism.
It's not the first one because he's given specific care based on a request. So like the patient like requested like that specific care. So it gave them like an option. So it gave them some autonomy. Number 2, that one is the answer because the doctor is just basically saying like, okay, option A is the best, so they should choose that. It's not really giving them an option to make their own decision.
Got it. Good. That's another way of saying it. It's not giving them the option. Beneficent paternalism does not give them the option to make their own decision. They make a decision, but the doctor says, nope, not the best decision. I know what's best. Option A says that the patient made a decision. Somebody made a decision and the doctor complied. He went along with it. They expressed their autonomy. And so, but that's not what beneficent paternalism is. So that's good. So we're taking what we know and applying it to the situation. Good. All right. Here's another one. Okay. Lisa, the nurse, explained it is implemented in extreme circumstances. And then Lisa, the nurse, explained it's implemented during routine care in circumstances, which is true about beneficent paternalism.
The first one.
Extreme circumstances. It's not something that you're going to hear and see every day. Something's extreme going on. All right, good. All right. True or false? Starting education is within the LPN scope of practice.
False.
All right. What would make this statement true? What word?
Reinforce.
Got it. Okay. So RNs do the initial teaching while LPNs can reinforce. Got it. So even if they use the word, okay, we said start education, initial, think about those words that mean the same thing. So starting, doing the initial education, we don't do that. We reinforce and do like the second teaching. All right. All right. So the legal aspects of nursing care. Remember, we just talked about the Nurse State Practice Act. And we said if they call 1-800-lawyer, they're going to look at that state. If you're in Alabama, they're going to look at Alabama's Nurse Practice Act. You're in Florida, they're going to look at Florida's Nurse Practice Act. Then they come back and they say, well, okay, they're working in hospital ABC. Well, let's pull that hospital's policies and procedures, because what did we just say that should match? The Nurse Practice Act and that facility's policies and procedures should match, because that hospital, that nursing home, that long-term care facility, that urgent care should not be asking you to do anything that's not in that state's Nurse Practice Act. So that's why the lawyers can pull those two documents and say, hey, this nurse did exactly what they were supposed to, or this nurse did not do what they were supposed to, because their documentation does not support these two things. Okay. All right. So legal aspects of nursing care. A healthcare organization's policies and procedures can be used in a court of law as one of the many guides for the expected behavior. Is the nurse expected to do this task 1, 2, and 3? Yes, because that's what's in the Nurse Practice Act. And then remember that facility's policies and procedure, they come right out of there. So as the Nurse Practice Act is revised, so should facilities policies, because it's illegal for us to be doing something that's not on our Nurse Practice Act. Okay. Where can we find the minimum competencies required for us to practice?
State website.
State Nurse Practice Act, which comes from that state's nurses website. Okay. So we get our scope of practice, those things that we can do. So the content of the Nurse Practice Act, remember this act is like a document. It's not a person. The Nurse Practice Act is this document. It's these guidelines that gives us our functions. It tells us, it also has programs for in the event that a nurse is impaired, may have a substance abuse problem. They do have professional programs that assist the nurse into recovery. Continuing education, it tells us those things that we need to do, the number of hours that we need to continue our education. Remember, we're life learners, so we're in order to keep our license active, an agreement that we make is to obtain whatever that number is for that state's continuing education needs. All right. So let's recap what we just said about the Nurse Practice Act. It contains those general information such as licensures, functions of the state boards of nursing, the elements of unprofessional conduct, and the process to obtain the licensure. So you may say, well, shoot, why is this school having me doing this? Well, the Nurse Practice Act in your state says, hey, these are the things that nursing school program must have in place in order for the student to sit for their boards. And then also it tells us those general functions, not specific functions, the general functions. So you need to know it does not give us those specific functions. The functions are general, because what happens? What if they give a specific function and we have nurses working in the hospital and then we have nurses working in the long-term care facilities? If those functions are listed in the Nurse Practice Act and they're so specific, are those the same settings? Long-term care and acute care? They're not the same settings, right? So that's why the functions that they list is general. So it'll have something listed as can do wound care, But once you go to that facility in the hospital, they may have wound vacs, they may have a wound nurse. Their policies and procedures will equal general providing wound care. But then they'll be more specific and say, hey, these are the different types of wound care that we provide. But then you get over in a long-term care facility, they might not have a wound vac, they may not have a wound nurse. So the functions are listed in general. The LPN can provide wound care. They're not specific. Okay. So the State Board of Nursing, that's what that website that we keep talking about. Each Board of Nursing has a website, and they have their governing body. Okay. So it includes approving nursing schools. So they look at they have to write this whole application. They have to have so much seat time. That's why it's so important for classes that meet once a week that you come that one day a week, because it says that you must have so much of seat time. And so if you don't, then that equals so much of being absent. And then two misses equals 14 days. So that approval includes that approving nursing schools and know the amount of time that you should spend at clinical. Like, okay, well, why do we have to have this many hours? Because the State Board of Nursing says, hey, we need to have so many hours in emergency care, in med-surgical care. So that's how you get placed in your different clinical settings. And then it has that inactive license list. So you have an option of, recertifying your license, or you can just let them lapse. So, but even if the license lapse, they're null and void. You cannot practice with them, but they still keep a list out there. Because what happened during COVID, when nurses had retired or they had let them lapse, many states contacted those nurses that were on those inactive lists. And, that what they had to do was whatever requirements to recertify. But they keep that list. So they keep your name out there on that list. The Board of Nursing develops programs for impaired nurses, but does not provide the counseling part. So they have these programs, and so they subcontract the counseling part to other healthcare professionals. So as another requirement of impaired nursing programs is the testing. You have to do the substance abuse testing every so often. So the board doesn't actually do the testing; they subcontract that out. So you have to report to certain facilities around town to provide your specimen. So the same thing, they have the program that say you must have a certain amount of counseling, but they don't actually do the counseling themselves. That's all they're saying. We need to know that. So we do have, I think we were talking about this in small group about, I don't know how we got on this, but someone mentioned fraud, I believe. I think I heard some of you all talking about it. But 8 categories that can result in disciplinary actions, meaning they're going to throw the book at you. You may be fined. You may have to do so much of volunteer time, but there's going to be some type of disciplinary action. So negligence, criminal activity. The patients, a lot of times they come into the facilities, they have their personal belongings. Someone gets their debit card and go grocery shopping. We can't do that. Violation of the Nurse Practice Act. The Nurse Practice Act says that you can do wound care, and then the nurse decides to debride the wound. That's not doing wound care. That's a whole different procedure. So that's violation of that Nurse Practice Act. Doing something that is not listed on that our to-do list or our Nurse Practice Act. That's what it means by violation. Okay, if you have any questions, let me know. We'll stop and talk a little bit more about it. If I do something wrong, the nurse does something wrong, what's the next step? Okay, we need to know this. A complaint is filed. The complaint is reviewed. An investigation is done. They have to investigate. Doesn't mean the person is going to be found liable or in the wrong, but we have to give them that investigation. It has to be done. So when does the nurse has the opportunity to respond, to give their side of the story? It is during the board proceedings. Board proceedings is where the nurse has the opportunity to respond. And then they'll have a conference, they'll have that hearing. And then sometimes, if there's a disciplinary action, they'll decide what it is. It could be a substance abuse monitoring program, or example, the nurse will have to report. They get the phone call, they have to go report. They're given so much time to go report to a facility to give that specimen. So the board's action, they can say, well, hey, we want to immediately pull or suspend or stop that nurse from working. So that's immediate suspension. If they're thinking that nurse is a danger to the public, then they immediately say, hey, your license is null and void. Disciplinary actions can also include fines. You have to pay money. They may take civil penalties. There might be some limitations of practice. I know some examples of that is the nurse can only work if a certain type of supervisor is in the facility. So they can still work as that license, but if they don't have, I don't know, 2 RNs working, then they can't work that shift. So whatever facility that they're at, and if that nurse is going to work that shift, they have to make sure that those provisions are there. Because sometimes they will limit, the practice. They may say that this person can only work day shift. So those are some examples of limitation of practice. But they can actually suspend or take the license altogether, that revocation. So these right here, we need to know about these 2 databases. The nurses, the National Database for Verifying. That's what they look in to see. It's like these huge file cabinets. These nurses, they just look in to see, well, hey, does this nurse have a license? Is it expired or is it current? And do that nurse have any disciplinary actions against them? It does not say where you live. It does not give your social security number, your shoe size, your favorite color. It does not do any of that. So if you go to Florida to work, you go to California to work, they're going to look in this database. And they say, well, hey, Nurse Lisa is licensed in this state. It expires September 1st. So they can work for a couple of days. No disciplinary actions. Now, this other data bank is like a huge file cabinet as well, this National Practitioner Data Bank. I think I have some more information over here on this slide. Oh, got that one out of place. Okay, here it is. I'm going to go back to those slides, you all. So this one is a huge system. This system keeps information about healthcare providers that are unfit. So if they've had some type of disciplinary action and they should not be practicing, that a healthcare facility, like for example, if Nurse Lisa goes to do a job application at ABC Hospital, the human resource staff should go into this National Practitioner Data Bank, look up Nurse Lisa's name, see that she has a license, if they have any disciplinary actions. And if they do, it's going to be listed there. Because what happened was practitioners were able to just go from place to place. And they had actually had some type of a suspension or license where no had been taken and nobody knew it. But then they created this national, I like to say, a huge file cabinet. So as a person commits a crime or have some type of disciplinary action, it's submitted to this data bank. So that information is there. The data bank has the nurse information whose license that has been suspended. That's where it is located at. Okay. Nurses, we just look in there and see who you are, the license number, expiration date, and whether or not that nurse has any disciplinary action. It does not tell your date of birth, where you live, and all those other things. Okay. Let's look at criminal and civil. So criminal, we have government versus an individual. It could be a felony or a misdemeanor. Crimes such as larceny and embezzlement, that's getting these folks money, doing things you're not supposed to be doing with it. But then in civil, we have intentional torts, which we'll talk more about that, or unintentional torts. So something happened to the patient that was wrong or bad, but one of them is intentional the person intended to, and the unintentional, they had a bad outcome, but the nurse didn't necessarily intend for it to happen. Okay. So an example of this unintentional, we did all our medications right. We verified our person. We have the correct medication. We administer that medication, and that patient has some type of reaction, anaphylactic shock to it. You know, we didn't intend for it. We did everything correct, but that person still had bad outcomes. Okay. And to piggyback off of one of the questions, and I think we went over this part, another question was, it asked about those things that are reportable. Remember, so if we give Tylenol, what's expected? If we give Tylenol for pain, what's the expected outcome? Pain goes away or it gets less, right? And so that person, is it expected that that person's throat should swell up and they have problems breathing just because they took the Tylenol? Nope.
No.
We should report that. Well, what about if we give a vaccine? We give a vaccination and that person starts to itch or develop hives at the site where we gave the injection at that vaccine. Is that expected?
We have to report that.
You got to report it. That's not expected. We administer that medication, whether or not it's vaccine, whether or not it's antibiotics. That person shouldn't be itching. That person should not go on an anaphylactic shock. We supposed to report all of that. We should report all of that. Okay. So this unintentional, like I said, the nurse did everything they're supposed to do. I did not mean to hurt the patient. And so, but for some kind of, in this example right here, the nurse did not do the 6 rights. And they gave the patient the incorrect medication. And so, which caused an injury. Okay. Liability is being responsible for something. So when we talk about network on your healthcare team, we're talking about assisting without, asking for help, without your team member asking you to help them. But we're talking about doing things that's not going to make you liable. For example, refreshing their water pitcher, helping restock their cart. We're not talking about anything that's going to have you to assume the duty of, are there any questions? Okay, we're gonna move on then. All right. So this is what I was saying. Don't do anything that you're going to assume duty for. So we do want you to network, but don't do anything that you're going to be responsible for that client, because in the event that something happened, these damages, an injury, damages, and they can make the connection between the nurse not doing this breach of duty is not doing what we're supposed to do for that client, and it caused some damages. They can make that connection. That means that we are negligent. Okay. Duty refers to the nurse's responsibility to provide care in an acceptable way. The nurse has a duty based on education, as well as the policies and standards of the place of employment. So the Nurse Practice Act, and then that facility's policies and procedures. The breach of duty means that the nurse did not adhere to that nursing standard. They did not follow what the Nurse Practice Act said that we were supposed to do. They will bring in, the lawyers will get an expert nurse. They will come in and say, let me look at this state's Nurse Practice Act. Let me look at this facility's policies and procedures. From that, they established a standard of care, or what should have been done. Then they look at what actually happened. Then they'll say, yes, you have a case. You don't have a case. So they bring that expert nurse in. Okay. All righty, battery. Okay. To cause physical harm to someone. And assault is that unjustified attempt or threat to touch someone. So battery is that actual contact, and assault is just that attempt or that threat. Okay. Chemical. We have a nurse that says, hey, you know, these patients have this medication prescribed for pain. Well, I'm just going to go ahead and administer it. It's PRN. The patients have not asked for the pain medication. The nurse did not go in to assess the pain. They just know that this patient has these medications ordered. And so they administer them without a cause, without doing any assessment. And so what is that? That's a chemical restraint. That is a crime. You're not supposed to do that. And the same thing for an example of chemical restraint, pain medication, what's some other things that alter the level of consciousness or alter the person's awareness. For the most part, pain medications, or if they're on some type of, that's why in the long-term care facilities, you will you'll be on one of those teams where they have to show a reduction of the medication because they want to make sure that we're not administering those medicines as restraints. So we have to show that we have reduced the dose so that that we're giving that patient an opportunity to not be chemically restrained. They want to make sure that we're not chemically restraining those patients. All right. So what's an example of a chemical restraint, you all?
Medications.
Medications that are being administered for not the reason why they were administered, even if the patient has an order. But an assessment has not been done and the patient has not asked for it. So an example of a physical restraint is a wrist restraint. And you can have vest restraints. It's anything that limits the mobility of that client. This they had these like the babies were in these walkers, the little thing that you put them in and they can actually move around. It has little wheels on. They had designed some for adults, but now they're outlawed. They're considered restraints because think about it, babies can't get out of those things and adults couldn't either because you have to be able to release it. So it was considered a restraint. A lot of facilities don't have bed rest. Depends a lot of long-term care facilities because they're saying that that is a home-like environment. And unless that patient has some type of chronic disease process where they had a hospital bed delivered into that home, our beds don't have bed rails on them. So a lot of long-term care facilities, you will not see bed rails. And if they do, they have some type of documentation that says that they use them for mobility or something like that. Because otherwise they're considered as restraints. Okay, so yes, so I got ahead of myself. So the chemical restraint, the nurse administering a medication, usually a PRN, because the nurse wants to, not because the client asked for it or a head-to-toe assessment was done and the findings suggest that we should. Physical restraint, the patient has on wrist restraints to confine the arms to one place to prevent pulling or dislodging a breathing tube. So that's wrist restraint, vest, they're all different kinds. Okay. So defamation of character. Look at my clock here. Make sure we don't run over our little break time. So defamation of character can be done through spoken. That's slander, that when you actually say something or if it's written down, it's called libel. So make sure we know the difference between slander, which is spoken. The person said, blah, 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 blah. Libel, they wrote it down. So be careful when you are sharing messages and things. Because if it's deemed defamation to one's character, everybody that shared it, because it's written, You could be. So just be careful with sharing things. Sending an email to the editor of the newspaper that's written, posting on social media messages or pictures that's considered written, and then false accusations on a performance evaluation. So that's written too, written in verbal or spoken. So steps for bringing a legal action. The client believes that the nurse has violated his or her rights. So, they call a lawyer, $1-800 lawyer. They bring in that nurse expert. Remember, that nurse expert is going to look at that facility's policies and procedures and also the Nurse Practice Act. And they're going to say, hey, the standard of care was violated or it wasn't violated. And if the standard of care was violated, meaning that the nurse did not do what they were supposed to, then a lawsuit is actually filed. Okay. And then so, the plaintiff files the complaint and everything is documented, that they pull up and show proof, or they have to show burden of proof, evidence of wrongdoing if they go to trial. Okay. Okay, so employment opportunities. Obtaining additional certifications, and you'll be able to do this when you go to different settings and facilities to work. Some of them offer classes and where you can get additional certifications, and so that's your certification. So what that does for you, you look different from the other nurses. So that enhances or increases your opportunity to be hired. In addition to that, most of the time, there's a difference in your pay because you have that certification. So obtaining additional certification will open up different employment opportunities, enhancing your employability. Okay, so the patient care partnership, it is what it says. This patient takes part in the care that they're receiving. We ask them what are their preferences. And that's where this DNR order, it came out of the Patient Self-Determination Act, but it went back to, hey, we're in a partnership. We're providing care to this patient, but what kind of care, what things does this patient want to be provided for them? Do they even know about their disease process? Do they know that they have different options of treatment? And so the patient care partnership, it helps us to, be therapeutic. Even if it's something that they don't want to do, they'll let you know. But a DNR, or do not resuscitate order, is based on the Patient Self-Determination Act. And it goes back to that partnership that we say we should have had from the jump. It's the patient that we're providing care for, but so we need to include their preferences and the things that they value. Okay, encourages the client to be a participant in their plan of care. We collaborate with the healthcare team, and the healthcare team includes the patient in making decisions about their care. What do they know about their care? What questions do they have? Do they understand what this treatment is that they're refusing? And we want to make sure that they make informed decisions. So we kind of talked about HIPAA early on, but it's the Health Insurance Portability and Accountability Act. Protecting a person's privacy. Protecting a person's privacy is what HIPAA is all about. So we do not share client information with other healthcare professionals that are not involved. But we can share healthcare information with other healthcare professionals that are involved in the patient's care. We do want to keep medical records locked and secure, even when you're not in front of your computer. A lot of facilities have that electronic records, and you have the computer. You want to make sure that screen is locked when you walk away, and make sure that it's secure. A lot of the computers that are on the walls, as people walk by, they have whatever that thing is on them, and you can't see them from the side. So that's a part of keeping people's information private. So providing health information to the client's family after obtaining patient's consent. Is this violating HIPAA, or is this being compliant with HIPAA? providing health information to the client's family after obtaining the patient's consent. Compliant or non-compliant?
Wouldn't it be compliant?
Yes. What about reporting instances of suspected child abuse?
Compliant.
Okay. Disposing of medical records, nurses' notes, cardexes. Usually cardexes, a lot of people don't even use those anymore, but there's just a sheet of paper or some type of thing with the patient's information on it. But we're disposing of those things in a designated protected receptacle. An example would be a shred bin. Is that compliant with HIPAA?
Compliant.
Okay, compliant with HIPAA. Let me go back to this right here. This first one, sharing client health information with other healthcare professionals involved in the patient's care. Remember, if they're involved, yes. For example, if we had the patient in the emergency room, they're transferred to med-surg, we are no longer involved, so we shouldn't be looking at any more of that patient's information. Okay. But if, as long as they are involved, then it's okay to share that information. We are mandated reporters. We don't have to have all the details, but if abuse is suspected, we have to report it. Gunshot wounds, we talked about that. Other criminal acts, we have to report those things as well. So incident reporting accidents, medical errors, sentinel events, it all helps improve patient safety and prevent future occurrences. So we want you to, report them, patient falls, patient sitting in chair, looked at hand and hand had a skin tear on it. You want to report those things and doing the investigation, we'll gather more information. It's like, what was this person doing? How did they fall? Did they not have on their non-slid shoes? Was the lighting appropriate? So this helps us to improve patient safety and prevent future occurrences by reporting those incidents. Okay. We got 1 more minute before we take our next break. So what information can we give out? Clients have a right to a copy of their medical records. Now, some facilities may charge, but they have a right. So we have a patient that's going home and they are supposed to get a hospital bed. They're supposed to get a cane, walker, crutch, some type of medical equipment. What is the minimum necessary rule or information that we should give out to that vendor? So we have this vendor, they're going to bring that patient that hospital bed, that walker, cane, or crutch, or whatever it is that they need. What information should we give out? We should only give out that client's name, the address, because when they got to deliver the medical equipment, and the payer information. They don't need to know diagnosis. They don't need to know date of birth, their favorite colors. They don't need to know any of that information. And in fact, if we do give out that information, it's violating HIPAA. So let me say this again. We're going to take our next break. The minimum necessary rule protects clients' privacy. So if we're dealing with vendors, the only information that they need is the client's name, their address, and the payer information. Okay? We're going to pause right here. We'll see you in 5. All right, let's bring it on back, you all. We're going to save our other 15 minutes toward the end. But hopefully we'll get through all the slides. But if we don't, I'll just let you all out and I'll continue to review everything. All right, let me share my screen again here. Make sure I don't have any questions. Okay. We are recording. All right, so client's right to consent. The client's right to consent to or refuse treatment. I asked you all earlier, I said, can the patient want a surgery done? Hip surgery, whatever type of surgery. But then, they always ask about blood and blood products. So they can choose whatever. They have the right to choose. So in the event that they need blood and blood products and they don't consent or give permission for that to be administered, then we can't administer it. So informed consent, we want to make sure that the client, the patient has enough information so they can make an informed decision. So what does that include? So it includes the diagnosis or the suspected diagnosis, the purpose and the description of the treatment. They have to be told what are the expected outcomes and the possible side effects. What are the benefits? A lot of times, people want to just talk about the benefits, but we have to also, a part of a person making an informed decision is letting them know, hey, we have seen these complications. These are the side effects that people have experienced by taking this treatment. And then an explanation of alternative treatments. This is what we recommend, but there are also treatment B and treatment C. We have to also give that information. The names and qualifications of the people who will perform the procedure, the prognosis if treatment is not done, answers to questions the clients won't clarify. So if they still have questions, then that means that, okay, so you tell me, what does it mean? If they say, hey, the patient in room 201, we keep picking on that patient. We've got informed consent, but that patient pushes the call out. We go to the room and the patient says, hey, I still have some questions about this procedure. Has informed consent been fully received? Has this patient fully given us permission or consent to go forward with whatever we're doing if they still have questions? Nope. Because informed consent includes answering whatever questions or clarifying any information. So in the event that they say, hey, patient in room 201, we've got informed consent, they push that bell and you go in, they say, well, nurse, I have a question about who is, I don't think I read that one out to you. Who is this? I did. Who's going to be working with my doctor that's doing the surgery? Is the doctor going to be doing it by themselves, or is someone else going to be working with them? So that means that this patient has not been fully informed of everything. Or if they have, they've forgotten. So we need to go back and get the names and the qualifications of everyone that will perform the procedure. A part of informed consent is also answering any questions, explaining that the client has the right to change their mind. Even if they sign off on it, get them on the bed and we're reeling them down to surgery, they can say, no, I've changed my mind, even after they have signed. Must be obtained for invasive procedures. Informed consent, we have to get permission, their consent to do chest x-rays, MRIs, bone scans. Informed consent means that the client is told the following in non-medical language, in layman's terms. I think you all may have heard of that. So it has to be in terms and information and words that they understand. And then sometimes videos, or they're shown videos, or they may be asked to go to a certain website to look at all that information before they actually sign off and give us permission, because we really do want them to have a understanding of what they're signing and giving us permission to do. Informed consent includes the names and qualifications, we said, of the people who will perform the procedure. And here we go. The patient states, Nurse Larry, nurse practitioner Lisa, Bob, the anesthesiologist, I know, who will be helping my provider with the hip surgery. Indicates the client does know who will be assisting the provider with the procedure. So that's just taking, let me go back to that one. Names and qualifications of the people who will perform this procedure. That's just taking that concept and put it into a scenario for you. So the patient states, hey, I know Nurse Larry, I know this, and they'll be doing this. So that means that they know. So that is part of informed consent. Okay. Informed consent includes the diagnosis or the suspected diagnosis, for example, a fracture of the right hip. The statement, I have signed a blood transfusion consent because bleeding is a risk of this procedure, indicates that the client understands that bleeding could be a complication of the procedure. Like I said, a lot of times, most of the time, they go ahead and say, if you need blood and blood products, would you go ahead and give us permission? Because otherwise they'll have to wake you back up and then say, hey, you need blood and blood products, and then administer it to you then. But that's after you recovered. So informed consent does not include cost. Okay. All right. So let's look at these advanced directives. So a living will. These are legal documents, you all. A living will not specify a person. So, for example, the patient in room 201 says, I have a living will, and it says that my daughter Lisa will make my healthcare decisions for me. Is that a living will that this patient has? Or is it a doable power of medical power of attorney? If the patient in room 201 says, my daughter or a person will make healthcare decisions for me, is that a living will that they have or not?
No.
No.
It's a durable medical power of attorney.
Exactly, because that specifies a person to make decisions. This living will does not specify a person. And so, but they both are legal documents. And this living will, it does tells us whatever that person's, wishes are. It's just in writing. It's not a person. So that's really the only difference between the living will. The living will is a document that we look at and read and we interpret. Say, okay, well, this person said they don't want IV fluids. They don't want to be transported. But then the durable medical power of attorney, that person is designated and they make those decisions. They determine whatever it is. And guess what? The durable medical power of attorney is legal in all 50 states. You need to know that. But a living will does not specify a person. It's a document with written guidelines. We talked about this earlier on another slide, a do not resuscitate order. Advanced directive based on that Patient Self-Determination Act. So we've created that partnership. We realize that it's very important for our patients to take part in and make some decisions about the healthcare they're going to receive. So that DNR, it is a legal document. And it comes from that Patient Self-Determination Act. Okay. So removal of life support. Let's read what these slides say. It says the doctor must pronounce the client dead and document this status before the nurse turns off the ventilator. Do we agree with that or we disagree? Or can the nurse just go and turn the ventilator off and pronounce the patient deceased?
What was the question?
The physician must pronounce the client dead and document the status before the nurse turns off the ventilator. Is this true or false?
Does that mean like brain dead or?
That's true.
So the person's deceased. No respirations, no pulse, no heart rate, no blood pressure. So this is true. Now, what if that nurse goes ahead and turn off the ventilator before the physician has pronounced that person dead? Is that legal? Is that ethical?
Unethical.
It's unethical. It's illegal. It's actually considered an act of murder. So the nurse must have a physician pronounce that client deceased before we DC or stop any treatments. And treatments include a ventilator. We can't turn that off until that person's pronounced. Okay. So some other unethical acts: giving a client a higher or a lower dose of medication that was prescribed, accepting bribes. Even if we go and administer CPR to a patient that's a DNR, that's unethical because we just said that these are legal documents that guides us about the care that we're going to provide to our clients. So if this patient has a DNR and we go provide CPR, that's unethical. All right. So let's look at these leadership styles. So we have democratic and the laissez-faire. We mostly see these two here. So democratic, there's a nice balance, and the concern is for the what the task is at hand, and also the employee. The democratic leadership style is predicated on the individuals, the team, council. All those mean the same thing. Is a group of people that are participating in the decision making. You know, with democratic, there's not one person that's making this decision. Laissez-faire, just it when they say laissez-faire, it kind of tells you exactly what it means. You know, it's just concerned with the employee. Nurse Lisa goes to break whenever she decides. Nurse Bob goes to break whenever they decide. If they want to go to break when it's time to provide care for the clients, it's okay. It's okay. It's a hands-off approach. Each person decides themselves what they want to do. That's that laissez-faire. Okay. So delegation versus an assignment. So the assignment are pretty much consistent with the job position and the description and the legal scope of practice. So delegation is when we transfer or assign tasks to another person. So we can do the task, but we assign it to another person that can also perform the task as well. So that usually that goes from a nurse to an unlicensed personnel, from a nurse to a CNA, from a nurse to a patient care tech. So a CNA cannot delegate or transfer their responsibility to another CNA. So it comes from the nurse to the unlicensed personnel. And we have a few more slides on delegation. Before you delegate, the client must be assessed. We want to determine whether or not this client is stable or unstable. Okay. And so if the client is unstable, it doesn't matter if it is a task that the CNA or the unlicensed personnel can complete. For example, provide a bed bath, weigh them. If those clients need those things done and they are unstable, we don't delegate that because we must first assess whether or not this patient is stable or unstable. Okay. And so delegation, once accepted, cannot be transferred. CNA can't say, hey, I told the next CNA I told them what to do. I delegated it to them. It doesn't work like that. Okay. So we do have some rights of delegation. These are the things that you need to think about as a nurse when we're trying to determine delegating a task. We want to ensure that whatever that task or that responsibility is, or that thing to be done, is in their scope. It's something that they can actually do. Is this the right circumstance? So for example, we wouldn't be asking a unlicensed personnel to be doing wound care, to be administering medication. Is this client stable or unstable? You know, is this the right person? You know, we talk about the patient in room 201, but is it the person that's in room 201 or 202? And we want to communicate the correct directions, those instructions. And then we have to go back and supervise, because if we delegate it, it doesn't mean that we are no longer have that responsibility of that task being completed. As a matter of fact, we still have the responsibility of making sure that that task has been completed correctly. Okay. So these are some things that routine tasks that we can delegate to the nursing assistants, but it's not anything like administering medication. It is not doing any wound care, but they can, you know, measure heights and vital signs. They're not interpreting vital signs. You know, they can apply heat and cold. They can collect urine and stool specimens. So these are some examples of duties not to be delegated. We do not delegate these. Sterile technique procedures, putting in Foley catheters, administering IM injections. We're not asking them to do these tasks. crisis situations, you must be there. The nurse must be there. An example of a crisis situation is a resident who develops chest pain. Although nursing assistants can collect simple data, they have not been trained to make decisions or interpret that data. So, for example, if they're getting finger sticks, if they're getting blood pressures, we shouldn't be asking them, well, hey, is this higher or lower than it was last time? They can obtain the information, but they should not be evaluating and making decisions about the data that is collected. Okay. What if a delegation is refused? The nursing assistants have the right to refuse a delegated duty. The LPN collaborating with the RN then questions. They determine why. They ask the question, well, why are you refusing? Because you just never know what's going on or what has happened. Why are they not wanting to completing the task? So ask the nursing assistant why they're refusing to perform the task. Okay, so this is just having us to think about before we delegate. What is their scope of practice? Do they have a scope of practice? What are those things that they can do? We want to make sure that this client is stable before we delegate those tasks. And then what are those 5 rights of delegation? Just talked about that. A lot of these slides are repetitive. Know the scope of practice for delegation. LPN, stable clients with expected outcomes. Okay. Remember, the RNs do the initial teaching care of clients that require frequent monitoring in unstable conditions. We just had that slide. Make sure you know those rights. Okay. Which of the following clients would the RN delegate to the LPN? Okay. Think about, is this client a client receiving an insulin drip? We're going to go back and say, is this client stable or unstable? If they're requiring an insulin drip, they're unstable. Okay. New admission. So new admission, the RN is going to have, but after they've been there a couple of days, then we can transition them to the LPN. Okay. Person's just post-op. The RN wants to, we want to make sure the RN take care of that patient. Okay. Which patient with a healthcare provider related with which patient with a health problem related to GI cancer would be the most appropriate to assign to the LPN? A patient who needs enemas and antibiotics. So as an LPN, we're not doing blood transfusions. We're not doing this preoperative teaching. And we're not taking care of this patient who needs a central line because this person's unstable. Okay. And these slides were in your this week's announcement. So I just pulled them to this PowerPoint. Okay. The assistant personnel reports to the LPN that a nurse's urine output for the past 24 hours have been only 360 cc's. What is the nurse's priority action at this time? So a test taking tip, when it asks for priority, when you read the answer choices, you might go like, we can do all of these things, and you might can. Go back to what the question is asking you. It's asking what should be done, what's most important, what should be done first. We want to contact and notify, the healthcare provider immediately. Okay. Which actions did the LPN delegate to the assisted personnel? Again, these are things that this patient is stable. They can do record intake and output. They can measure the vital signs. We're not asking them to interpret the vital signs. And they can assist the patient with turning and repositioning. Okay, we have these 4 patients who come in, and which patients requires the most rapid action by the triage nurse and the LPN assistant to protect other patients from infection. So we have that 5-year-old who has that pruritic rash and possible measles. Why would we isolate this patient that has measles. What is it about measles?
It's very contagious.
It's contagious. Exactly. So we want to protect the other patients because it said infection control. So that was your key. Okay, which one of these is going to lead to the spread of infection? Good. So which intervention should the nurse delegate to the assistive personnel? Again, we're not asking them to interpret anything. We're not asking them to be teaching anything. So they can assist the patient with walking, ambulation to the bathroom in the halls. We're not asking them to be collaborating with others on the healthcare team and identifying environmental risk factors. That's what we're going to be doing. So we talked about the minimum necessary rule. We want to protect the client's privacy. So if that medical company has a bed to be delivered, we're going to only give them that patient's name, their address, the payer information, that's that insurance information, and that's appropriate for that nurse to disclose. We're not giving out social security numbers. We're not giving out diseases. Well, what this patient got? They got hypertension. They don't need to know that. Minimum necessary rule. They need to know who they're delivering to, where they're taking it to, and how they're going to get paid. Because we're talking about the vendor of medical equipment. Okay? Which of the following can be delegated? You got 3 examples on the screen. Which of the following can be delegated? 1, 2, or 3?
1.
Okay, we say 1. That it? Which of the following can
All
be?
of them.
All of them. Okay, good. Okay. So change your shift. You're going home and I'm coming on. We sit down or we do bedside. We walk around to the patients that I'll have. That information that you give me is my baseline report. So as I take care of this patient throughout my shift, I have the information that you gave me to compare it to. Your information serves as my baseline information. Okay. That's that change of shift. That's what we're exchanging that information for. So I can quickly recognize, this patient was alert oriented ×4. When I go in, they're hard to arouse. And when they do arouse, they only know their name. I can quickly identify compared to their baseline that this patient has changed. Okay. So we talked about increasing employment opportunity. We talked about obtaining those certifications, you all. You want to attend seminars, you want to network, read books and articles, real life learners. We're all the time trying to increase our knowledge with the latest, greatest information. But getting those certifications, in most facilities, you'll get an extra pay. We kind of talked about this sexual harassment already too, but we'll go back over it. Ensuring a safe workplace is a responsibility of the employing institution. Sexual harassment is prohibited. Now, sexual harassment includes suggestive jokes, touching, pressure from a coworker, and open displays of transmitting sexual-oriented photographs. You go to the fax machine and they've sent something over. There's a poster posted in the break room. These things are prohibited. If the nurse believes he or she is being subjected to unwelcome sexual conduct, these concerns should be reported immediately to the nursing supervisor. Any questions so far? Any more questions? I have about 10 more slides to go over, and it's time for you all to go on your break, but I will continue talking through these other 10 slides. I want to be good stewards of your time. You can stay on, but I'm going to record, and as soon as I finish recording, I'll upload it I have to download it and upload it, but send it out. Make sure that you go back through these classroom recordings, you all. I assure you all, we cover all of the information. We talk about it in different ways. I give you scenarios and everything. If there's a question about any one concept, please ask a question. You do have exam 2 next week. If you do that exam proctored on campus, go ahead and send an email to your campus dean. Include myself and Dean Brown in it. at least 72 hours prior to exam day so that everything can be arranged for you. You all have a good night, and we'll see you next week. Okay. Civil action. In cases of negligence or malpractice in nursing, legal action is typically pursued through civil proceedings where the focus is on compensation for the injury rather than imposing criminal penalties. So civil focuses on getting money as a compensation for whatever the act that they thought was incorrect. We talked about justice earlier is providing that fair and equal treatment to all clients, regardless of their pay status, regardless of their history, their alcoholic, their whatever. We still provide that best care for our clients. Let me make sure we're recording. Yep. Autonomy, auto, refers to that client making that decision. What's my next steps? What treatment options do I want to have? That client is making that decision, and we support them in that. They have the right to make the decision. Okay. The purpose of the change of shift report provided to the LPN to the oncoming shift. So you're getting ready to go home, and I'm coming on. What's the purpose of providing that change of shift report? It provides that baseline, like we just said. So when I go and assess my client throughout my shift, I look at the information that you gave me and I compare it. Has this patient changed, or are they still the same? Have they improved or have they worsened? The information that's given at that change of shift is that baseline report. Okay. Which of the following should only be completed by the LPN? So we have 5 patients. The LPN, the patient in room 201, they have a dressing, meaning a wound change. The patient in 201 needs to be weighed. The patient in room 201, they need to walk in an hour. They need some pain medication. And they have a lead catheter bag that needs to be emptied. So which of these is appropriate for the LPN? So the LPN can do the dressing change, and they should be administering the pain medication. The unlicensed personnel, they can weigh the patient, they can walk with them, and they can empty the catheter bag. But an unlicensed personnel should not be administering medication, and they should not be doing dressing changes. Okay? All right, so here we go again. Which of the following should only be completed by the LPN? Collecting data and information on heart or the circulatory system, respiratory, lung breathing status? Yes. Can the LPN coordinate? When we talk about coordinate, we're talking about what can the nurse, the LPN, call or notify the respiratory therapist that they have a prescribed order. Like the doctor ordered nebulizer treatments, the doctor ordered an inhaler, the doctor ordered chest percussions. Can we coordinate that call and notify the respiratory therapist that they have this prescribed order? Yes, we can. We're just calling and telling them about the order that's in. That's all that's saying. Can we reinforce education on how to use an inhaler and send a spirometer? Yes, we can. Can we administer prescribed medications for various disease processes, diabetes, schizophrenia, bipolar, hypertension? Yes, we can. Okay. So, which of the following should be completed by the unlicensed personnel? Sometimes they have the title of a CNA or a patient care tech. So, the unlicensed personnel can weigh the patient, and they can empty this catheter bag, but they should not be doing any dressing changes, and they should not be administering any pain medications, but they can weigh, they can walk with the person, and they can empty this catheter bag. Nurse Lisa asks, where are minimum competencies required for an LPN? Where can these things be found? The Nurse Practice Act has the minimum competencies information required for an LPN. Okay. The nurse will determine the client's stability, whether or not they're stable or unstable, prior to delegating a task. So before I can assign this patient to anyone, I need to go in and assess whether or not this patient is stable or unstable before I delegate it. The nurse should monitor the activities of the nursing assistants when they carry out those delegated duties. We just talked about, even though we delegated, it is still our responsibility to ensure that the tasks are being completed. So we have a question here. True or false? Delegating tasks is only the responsibility of the registered nurse. This is false. I thought I had it on the next slide, but it's false. So remember, both nurses can delegate, the RN and the LPN, but the CNA cannot delegate to another CNA. Okay. We've had this information on a previous slide. A durable power of attorney is an appropriate document. It's legal. It designates a healthcare proxy. What is a healthcare proxy? It's a person. A durable power of attorney tells or leaves information that says, hey, my niece, my sister, this person can make those decisions for me. And it is valid in all states. Okay. Again, this is saying the same thing. A durable power of attorney for healthcare authorizes, give permissions to a person to make medical decisions for the client if the client is unable to make decisions for themselves. Okay. A living will does not specify a person. It's a document that has written instructions, wishes of the patient. It has written instructions.
Bye.